Okay, so our presentation is going to be on Parkinson's disease mid-stage, and our patient is Rick Sanchez.
So Rick Sanchez is a 70-year-old male who was diagnosed with mid-stage Parkinson's disease 2 years ago. He is a scientist as a hobby who works in his garage 24/7, is around pesticides and chemicals on a regular basis. His balance has gotten noticeably worse recently, noting that he has fallen more. So he's surrounded by his family. He has a good outlook on therapy. He's highly motivated to continue to go on adventures with his grandson, Morty. He's a retired rock star bassist, a current at-home scientist as a hobby. He has a difficulty complying with family and friends. He has anxiety and depressed tendencies. He lives with his daughter Beth and her husband Jerry and two grandkids, Summer and Morty. His grandson Morty is his favorite and is always spending time with him. He lives in a one-floor ranch-style home and spends a lot of time in his medium-sized garage, which has one step to enter and has his own room with within his daughter's house. There's a stool at the desk in his garage that he can sit in while he works. He has a history of heavy drinking, has a nihilistic thought on religion, and is previously married but is now divorced.
So just a quick summary of how Rick presents to us in the PT clinic. He's a 70-year-old man who comes into therapy today and says that he's been experiencing an increase in the severity of his symptoms of slowness and movement, tremors in his right hand, as well as an increased feeling of fatigue. He describes that feeling of fatigue as it makes it feel harder to walk and do his normal everyday tasks. Some important things he says around he has been experiencing some difficulty with regular tasks, such as getting around in his garage, because he experiences quote unquote shaking, and noticed that a lot of his movements were much slower and had difficulty to quote get going. His daughter also came in with him today, says that he has difficulty entering his garage from the side door and experiences moments such as quote unquote freezing and needs some cues / guidance to help him get inside the garage. Like we said earlier, he lives in a one-floor ranch-style home, which makes it easier for them not to have to manage stairs, going up and down stairs. And then he also mentions a big thing is that he is unable to smell his daughter's food as he knows how much he loves her chili. He is currently taking levodopa and says that he notices when he takes it that his shaking and slow movements improve, but then the medication quickly wears off.
Upon assessment and reviewing his systems, in terms of sensory, he cannot activate large enough muscle force to counter displacement, which would lead him to have anticipatory postural reactions. In terms of motor, he is experiencing hypokinetic disorders, excessive BG inhibition of motor thalamus, BPM, and the MLR, is experiencing postural instability, tremor, lead pipe cogwheel tone, and gait abnormalities. In terms of gastrointestinal, he is experiencing constipation, incontinence, dysuria from long-term effect of levodopa. In terms of cardiopulmonary, he has a decreased endurance, orthostatic hypertension, and dizziness. And when it comes to integumentary, he's experiencing skin breakdowns due to increase in his falls. And a good habit of a PT is that we would do is we must look out for signs of skin tears or tissue damages because of the increase in falls. When it comes to neuromuscular assessment, he experiences slowness of movement, unsteady walk and balance and coordination, tremor, and stiff muscles. And so next I'll be showing you guys video of Rick working in his garage. Let's give it a second.
I'll be in the garage.
So this is his lab that he works in, and as you can see how many chemicals he's exposed to. And these are all his gadgets that he uses, that he works with his hands. And here he is drinking, as he typically has these habits. He's currently always drinking. And you can see here his posture is stooped. He has no facial reactions. He's experiencing anxiety and depression. Maybe this is why he's completely always drinking. So as you can see here now, he's bending down, reaching for things, reaching for his beakers in the cabinet. to kind of perform the things that he needs in his garage. He also has these gadgets. He has the drill with him. So as you can see how Parkinson's disease can be difficult for him, because he needs to do all these things with his hands, especially with the bradykinesia that he's experiencing. All these tasks that he's doing in his garage would be very difficult for him to do.
Show me what you got. You're always talking, but you're not playing. It doesn't match your face. Cause I'm away from this place. Can you
That's just a little clip that we wanted to show you guys. You can put a picture to the patient.
Okay, and when we start his problem list, we want to start with his impairments, some important ones with his gait, the shuffling gait that his daughter mentions with the difficulty getting into the garage, difficulty initiating gait and movements, as well as difficulty with narrow spaces, kind of important for where his stool is at and where his little workspace is kind of tight. And then he hesitates with turning, concerned about ability to work on projects in his garage, and he has issues with coordination and upper extremity goal-directed tasks. When it comes to his musculoskeletal, he has the resting tremor, his jerky movements in his right dominant arm, making it difficult to work on small projects, the increased stiffness in his upper extremity, his decreased range of motion, cogwheel rigidity tone that we talked about earlier, and then his mild thoracic kyphosis and a stooped posture and standing. And then another thing we wanted to touch on really quick was the psychosocial impairments that he's dealing with, and that's his inability to sleep, and then a decreased mental health as a side effect of his medications. The next thing we wanted to look at were some ADLs, and he really is unable to perform basic movements in the garage, such as reaching, bending, and walking. He has difficulty maneuvering in those small spaces, like I mentioned before. He has difficulty with sit to stand, stand to sit, and standing pivot. And that's going to limit his mobility within the home and his garage. And then he has an inability to communicate effectively, like we saw there in the video, with difficulty with his facial expressions and impaired articulation.
Continuing with the problem list that Rick is experiencing here in terms of participation restrictions, he is experiencing the amount of limited ability to keep up with his grandson on adventures due to his gait issues. And he also has limited ability to continue playing bass guitar, has limited ability to clean his garage, and has a limited ability to watch his grandkids twice a week.
So some outcome plans and goals, some personal goals, be able to navigate in his garage as he's working on those small projects and decrease that freezing gait to be more efficient, be able to participate in those fun projects with his grandson, Morty. When it comes to clinical goals, we took a couple of the outcomes measures like DGI. We want to go from a moderate to a mild impairment. In his tug, we'd like to see it get down to less than 15 seconds. And then we want to improve his upper and lower extremity range of motion as well. Patient education, kind of important for this because it also reaches into his family. We want to do education for his family as well. And that's to teach the patient and the family about progression of disease. So the self-management of the on-off times, the effects of gait and postural instability, and some motor coordination. We want to teach encouragement to continue to participate in his hobbies and adventures because that's really important for Parkinson's patients. We want to teach about the importance of diaphragmatic breathing for his anxiety and to improve respiratory function, and then the use of rollator for mobility and to prevent falls, like the next bullet point says.
Continuing with outcome plans and goals, we want to develop environmental strategies for him. So initiating movement and turning as he's ambulating in the community, be able to reach for beakers and chemicals like we showed you in the video in the cabinet. And this will kind of help him work on his upper extremity range of motion from the stiffness. And then we also want to work on setting up a ramp for easy entrance to his house. Utilization of the bright colored tape at the entrance, hence how we've learned in this class, putting the tape on the ground to help him with his visual cues. And this will kind of allow Rick to bypass his basal ganglia to overcome his freezing of gait. We also want to work on interpersonal or social strategies. So we want to kind of have him kind of go back to his norm again. So being able to meet with his friends at McDonald's every Sunday, making it something like this so he can kind of get used to his routine again But we also want to make sure that someone's always with him in case he falls again. So in this situation, maybe someone like his grandson Morty would be nice to be with him at certain times. So, and in terms of participation in goals, we want to make sure that he's using his rollator for mobilization. We can teach him that he could use this as a backup in case he becomes overly fatigued or he needs to sit or become stuck in his gait. We want to make sure that we assign him specific words for practicing, using like descriptive words when he's around others who are having a hard time reading his expressions.
So a few of the interventions that we talked about that we would want to put Rick through, like we talked about earlier in this class in lab, some obstacle training. So we talked about aquatic and land-based obstacles training with auditory cues. Being a retired bassist, music, I'm sure, plays a huge part in his life. So playing to that strength and being able to utilize that is going to be really important for us. The Rock Steady program for improvements in gait and decreasing freezing of gait, also focusing on the diaphragmatic breathing of it. Forced cycling. So I was reading an article about forced cycling where the faster you can get the patient to move, the better it is for their connections in their brain, because you always want to go above the voluntary pace that the patient sets for you. And that's to improve stiffness, weakness, impaired coordination, and other Parkinson side effects. We talked about stretching exercises in order to improve the range of motion in the upper body and trunk. A home exercise program that includes Nordic walking, following a narrow path with guidance nearby, sit balancing on a Bosu ball with weight shifts and reaching, sit to stand activities such as partial sit to stands or teaching the nose over toes technique. And those are going to be aimed at mobility, balance, and core strength. And then, like we mentioned earlier, again, patient education on the medication effects. So those on off times and when the best time to exercise would be. So referrals and adjunctive aids. So there are a lot of referrals that we could make with a Parkinson's patient that we think would really help Rick. But some big ones that we wanted to mention, make sure we pointed out, were support groups, both for him and for his family, because Parkinson's can be such a difficult disease and diagnosis to deal with. It's important that there are people there to talk to for both the patient and the family. Occupational therapists to help with the little intricate movements and activities that he wants to do, keeping up with his hobby, feeding himself, that kind of thing. Respiratory therapists to help the patient with increased lung capacity and work on that diaphragmatic breathing to assist with his anxiety and increase oxygen take. And then the ATPs that we talked about at Miller's the other day, because we always want him to have the best device possible for himself to kind of prevent those falls. And then as the disease progresses, if he does need something further, it'll be important that they're there for him.
So continuing with the referrals, we want to make sure that Rick's visiting his PCP often as when he's scheduled, but most importantly, also seeing his neurologist, because the neurologist will kind of periodically assess the progression of his disease, and that way he can prescribe and adjust medications over time, especially with the levodopa. Nursing also plays a big role here, especially since when he was at the hospital. And then a big one here would be a mental health specialist. And as you can see, how PD can negatively affect someone's mood. And so with Rick having anxiety and depression, I feel like having a mental health specialist will kind of help him kind of deal with the issues that he's going on a daily basis. And in terms of home modifications, like we mentioned before, something like ramps would be nice to include in his home. Bathroom rails and grab bars, especially since he has that stoop posture and then the balance issues. I feel like having those around the home would kind of decrease the risk of falls. And then assistive devices like a rollator, like we said, if he gets tired, it's a perfect device to use. He can lock the brakes, he can sit down if he has a freezing of gait, if he gets tired or anything like that. So a rollator is the perfect device to use with this patient. And in terms of advocacy, well, we want to develop a home exercise program. We don't want to deviate too much from what he used to do. So we want to kind of allow him to do the things that he used to do, but also follow a schedule so that he can perform the things that he likes to do, especially in his garage. It's the most important place for him. And, you know, the exercises we want to include are aerobics, balance, deep breathing, and his walking as well. So, and here are our references. and we appreciate you guys listening. Thank you.